Christian Rolfo, and his talk is going to be about driving mutations in lung cancer, hitting the new and old targets, and what is the immunotherapy role. Professor Rolfo.
Thank you very much for the introduction. So we will come back to a little bit back to the EGFR and all the TKI history, because I think it's very important, and I congratulate the organizer to include this part in the session, because it's very important to remind a little bit what is the success in lung cancer therapy that we get from TKI. And also in the last part of my presentation, I will include some data regarding this TKI with the immunotherapy as was discussed before. So we know that in lung cancer we break with immunotherapy an important barrier with overall survival and progression-free survival. But the history starts in 2004 also with the TKIs. EGFR and KRAS were the first two drug-able targets mutations that were discovered. Actually, unfortunately for KRAS, still we don't have a real drug-able target, so we know that it's a prognostic and predictive biomarker, but we don't know other type of treatment. So we have MEK inhibitors currently, but they are not really working like we hope. The history in 2016, I can say, is currently we have a very big number of drug-able targets, including new biomarkers like NTRK. I will show you some data about that. And also, obviously, the immuno-oncology. But lung cancer was the first epithelial disease, cancer disease, who was treated with a TKI in first line. That was erlotinib and gefitinib were the first two inhibitors. And the history of success with this TKI continued to grow. We have second-generation TKI like afatinib. You have here all the randomized trials in first line, improving in overall survival, progression-free survival, and response rate. Unfortunately, after a honeymoon period between the biomarker and the drugs, the honeymoon killers that are the mechanism of resistance coming up, and you have here the majority of them. 50% of our patients are progressing with T17IM mutation, that is an acquired mutation. There are also ex novo mutations, so that some patients that we know nowadays with the next generation sequencing that we are able to catch in some percentage of patients T17IM, but that doesn't mean that this kind of population will not respond to the first generation TKI as well. But coming back to the resistance, 50% I say T17IM, there are other mechanisms of resistance involved like MET amplification, BRAF mutations, and even one special figure that we have that is the transformation between a non-small cell lung cancer to a small cell lung cancer. Currently, with this translocation, with this transformation in the tissue, we have some data coming from the liquid biopsy with some of the biomarker. For example, a retinoblastoma 1 mutation can be correlated with this transformation. So that are some important data that we have in order to include liquid biopsy in this setting. So an important concept that we need to remember when we are speaking about T17IM is that these kind of mutations have special considerations. One is that clonal evolution, so some clones with positive and negative T17IM can coexist. We have another important topic that is the T17IM loss, that is a mechanism of resistance in some cases, but it's also a response. We will see also that. And we need to consider that some patients can have also an heterogeneity, spatial heterogeneity, intra and intertumor heterogeneity as well. So that's happened. We have some patients that are leading the progression by clones, and we have another clones that are driving this progression, for example, MET amplification. This is the timeline of all the EGFR TKIs, and you see that they are growing very fast. And actually, in the last in 2014 and 2015, we have the inclusion there of the third generation TKI. The first one was, and the only one that is approved at the moment is osimertinib. We have here a list of drugs. Unfortunately, rosiletinib is a bad history, or we can say a sad history for FDA, because they approved the drug basis in the results of the immature data, and later on when the data became mature, unfortunately were not so powerful like we expected or we suppose in the early clinical trials. The AURA3 trials demonstrate that in the T17IM positive patients, there is an impact in the progression-free survival compared with chemotherapy, that is the platinum-based chemotherapy, and you have here a progression-free survival of 10.1 months compared with 4.4 months, and a hazard ratio very nice, that is 0.30. So it's a very nice hazard ratio and very robust data for our patients. With this data was approved the drug for patients with T17IM positive. Actually, if you look, one of the major concerns that we have in lung cancer is the brain metastasis. And regardless the presence of the odds and of brain metastasis, you have an important also achievement in progression-free survival when you use osimertinib compared with chemotherapy. The important thing of this key message of osimertinib in brain metastasis is the time that we are able to see the response. So you see there 6.3 weeks. So that means that in some cases we have some patients that we are able to delay or even avoid the radiotherapy in brain, and that is important because we know that deleterious side effects of radiotherapy in our patients in the brain especially, because these kind of patients are living more and more and more, and we will use in the future maybe this tool in some part of the history of these patients. In the FLAURA data, that is this a trial that is very elegant trial that include their osimertinib in first line compared with the standard of care, and the standard of care was considered 2 because we are using actually in our clinical practice or one or the other. So we have here gefitinib or erlotinib, and the randomization was 1-to-1. Crossover was also allowed after the standard of care. You see here brain metastases were allowed as well, and the EGFR mutation, the majority of the patients with the common mutations were included. The majority were exon 19 deletion, 63% in both arms. The primary endpoint was progression-free survival, and here you have the results are really strong results for first line with a drug that was designed in the very beginning for T17IM, and here is not this the case. Is in first line. You have here a disease control of 62% and hazard ratio of 0.46. And the data in the progression-free survival, like you see here, 18.9 versus 10 months for the in favor to the osimertinib arm. In the forest plot analysis, all the tumor types and all the histologies, smoking, history, and even the different kind of common mutations have an important activity in favor to osimertinib. And again, brain metastasis, independent of the brain metastasis absence or present, you have an impact in the progression-free survival. Duration of response is very important. Here you have a 17.2 months of duration of response with osimertinib compared with the standard of care, that is gefitinib or erlotinib. And also if you compare the overall survival in the interim analysis, obviously here is very preliminary because when we're presented in ESMO this year, only the 25% of the data were analyzed. And you have here anyway an important trend to go for a positivity in the trial with a hazard ratio of 0.63. What happened with the liquid biopsy? I told to you that the liquid biopsy we have before EGFR mutated patients T17IM positive in free DNA are able to receive osimertinib according to the approval of FDA. And you see here the concordance between the COBAS tissue analysis, and the free DNA basis in beaming. Beaming is one of the most accurate methods that we have, together with digital Doppler PCR, and also together with next generation sequencing. You see here that it's a very important concordance to diagnosticate the T17IM positive patients. According to the next generation sequencing, the COBAS tissue is also very high. So we have next generation sequencing is for us one of the preferred methods that we have. Actually, ILCC is ready to publish the guidelines of liquid biopsies in lung cancer, and we agree in the expert panel that the COBAS version 2 in free DNA is very weak to detect T17IM. It's around 50%. So The idea to combine other methods like next-generation sequencing allow us also to discover other mechanisms of resistance beside the digital Doppler PCR or the COVAS version 2. Another important concept that was included in the last World Lung Cancer Congress was the possibility to see what happened when the EGFR mutations are clearance during the treatment. So if you have here in the first part, in the first part of the slide, progression-free survival at 3 weeks and at 6 weeks in the other side. So after 3 weeks, when you have a clearing of the mutations of your patients after they start the treatment, you have an important impact in the progression-free survival, and the same happens when these patients have a clearance of the EGFR mutations after 6 weeks of treatment. So this clearance of EGFR is a predictive biomarker for foresee what will be the future of these patients in treatment with osimertinib. Unfortunately, we are meet another medical unmet need, that are the mutations, acquired resistant mutation for the third generation TKI, but also the T17IM loss, so the patients who have T17IM negative and we don't have other treatment for them. So you have here the mechanism of resistance of the third generation. Majority of the patients continue to be T17IM, but also, and I can tell to you that we have some experience with some patients that have 2 different mechanisms of resistance together. So you need to see which one is the driver and the co-driver. And here you see also there are other mutations like T79, T797, and that is 21% of our patients. But it's not only related with osimertinib. The other TKI third generation also demonstrate this kind of mutations. Actually, in the FLAURA study was an analysis performed in the sample of the free DNA of the patient demonstrate that they have also new acquired mutations that we are not able to see in the very beginning. So there are several questions about to go for the third generation TKI in first line, but obviously there are robust data, and we need to see what happens with the overall survival in the future. The strategy is to combine immunotherapy is very attractive because when we are combining EGFR or TKI in generally with anti-PD-L1 with immunocheckpoints inhibitors, you are speaking about the antigen presentation theory. And the former speaker spoke about the Tattoo trial, and in this trial was very positive, but unfortunately was also very toxic. And several of the patients have an interstitial disease pneumonia, and that is very important to consider because can be a lethal situation for our patient. For the reason this trial was stopped. There are several new combinations. Actually, ceritinib actually was combined with nivolumab. The data that we have in this trial for ALK inhibitors, ALK inhibitor in combination with nivolumab was not positive, so there is not an addition of benefit when you add nivolumab to the ALK inhibitors. Some surprise coming there. We will discuss, and some of the chairmen raised the question about what happened with the patients with EGFR mutations and PD-L1 treatment. So we have several meta-analyses. This is a meta-analysis published in 2017 in JTO, and you see that using these 3 trials, Checkmate 057, Keynote 010, and the Poplar, it's not clear the benefit for these patients with EGFR mutation with immunocheckpoints inhibitors. The same is another conclusion of another trial with ALK inhibitors. You see there the response rate, overall response rate are very low when you are using PD-L1 inhibitors in EGFR or ALK translocated patients. The OAK trial demonstrated also that the EGFR mutated patient, even if it was not a big number of patients, only 10% in the trial, was in favor to the chemotherapy instead of atezolizumab. So we need to be very careful with this kind of results. It was recently, this week, published this article that actually there are several limitations for the article, but it's important to consider that some of the patients who have interstitial pneumonia can come also from the combination or the monotherapy of, for example, in this case, nivolumab for EGFR positive patients. The IM Power 150 also including 13% of patients with mutations, EGFR mutation or ALK translocation. Actually, these patients were not included in the intention to treat analysis, but the analysis, the preliminary analysis, demonstrate some positive data with progression-free survival with a hazard ratio of 0.56. So that is very open a new discussion what we need to do with this patient. Obviously, if you ask to me, I will say if you consider all the treatments for EGFR and all the mechanisms of resistance that you get from EGFR, so when you exclude all of them, not only T17IM, we can treat the patients with immunotherapy if we don't have other options, if the patient have PD-L1 very high positive. But remember that chemotherapy is also an important tool for these patients still. The unusual suspect, we have also BRAF. We know that BRAF in lung cancer is very low, it's 1.4% in the cohort, in the French cohort and in the American cohort. Majority of the patients that we will find, and that is important when you will be very careful when you read the report, you will find several patients who have BRAF, but it's not 600 mutations, so these patients are not the target. When we have, that was presented this year in World Lung Cancer Conference, patients who have PD-L1 high expression but BRAF mutations, the overall response when they have even more than 50% is only 17%. So be very careful to treat these patients with immunotherapy before, and the same happens when you have here the 600 and not 600 mutations. So be very careful because the response rate that we have with these patients in combination of dabrafenib and trametinib is 64%. So the majority of the benefit that you can get for the combination is not comparable with the PD-L1. So we are very fascinated with the PD-L1 history and the immunocheckpoints, but we need to select the patients in the proper way. The same with overall survival, and you see here important benefit for our patients when you are selecting the correct patients. What happened with c-Met? c-Met is also a very important pathway, but there are several alterations there. In the beginning, we believed that was the overexpression, the main alteration, but we know that the amplification is the focus for lung cancer, with including complete response when you are treating the patient with a high ratio of amplification. And the new entry for MET is the exon 14 skipping mutation. And this alteration, when we are treating patients with PD-L1, you see here, when they have this alteration, the response rate is 6.7. So be careful because we need to select these patients for the right therapy. Because if you are treating the patient, for example, with crizotinib, that is also a MET inhibitor, the response rates are incredible, like you can see here in this waterfall plot analysis with crizotinib in exon 14 skipping mutation. KRAS, I told to you that we don't have still a target, a drug for a KRAS, we don't have a drug for KRAS, but the analysis show that KRAS is a predictive biomarker for response of immunocheckpoint in favor to immunocheckpoints inhibitor when you have the presence of KRAS mutated, even if we know that KRAS mutation is a worse prognostic biomarker for our patients. In the analysis of the atezolizumab in first line, you see here the overall response rate were higher when you have patients with KRAS mutated compared with KRAS wild type mutation. A special consideration to finish, we are using next generation sequencing and we are very excited of next generation sequencing, but we need to be very careful which kind of method we are using and if we have a method in our institution that is really validated or not. This is an example that was performed by Malapelle, and you see here several big institutions are failed when they have test some of the biomarkers. So we need to be very careful. We need quality control and validation. Obviously, it's a tsunami of information when you get this kind of commercial platform for more than 600 mutations. We need to be very careful with that. We need to work in a proper way to analyze which one is the driver, which one is the co-driver, or the passenger's mutations. For this reason, in our institution, we are working with molecular tumor boards, and that is the future. We are now publishing our data in molecular tumor board, and we have a big concordance when we are working with liquid biopsies and next generation sequencing in tissue. So we are using this kind of levels of evidence, that is the level of evidence of memorial slow catering. I suggest you to see the website in order to give to the patient the best option for them. Why it's important to go for next generation sequencing? Because you will find some of the alterations that you will never expect to find. This is, for example, the case of NTRK. NTRK mutation, fusion is one of the most important new entries, because as you can see here, several of the adults and infants can have this kind of alteration. You see here, in lung cancer is not so high, but I have, for example, patients treated with pancreatic cancer in our phase 1 unit with more than 1.5 years of treatment. So response rate in this cohort of lung cancer patients, I finish it, is 76%. So you need to find these kind of alterations, and the only way is searching for that and working with the next generation sequencing. This is a case, for example, of a lung cancer patient with a good response after several lines of treatment. So in conclusion, lung cancer is changed. We need to forget the clinical classification, clinical selection of our patients. We need to test our patient with next generation sequencing, and we need to be very careful, because we are very excited about immunocheckpoints inhibitors, but the history for the patients with TKI drug-able targets is completely different. Thank you very much.